Welcome to the Protecting Your Nest podcast. One of the best ways to protect your nest is by making sure the knowledge you are putting into your brain is based on the most up-to-date and available evidence. Like a good scientist, you must be open to new ways of thinking by challenging your previous beliefs. That's what my previous guest, Tim Noakes, was able to do. Tim was a long distance runner, and then he went from recommending a high carb diet to one where a low carb diet is emphasized. Now, this change was brought on because the preponderance of the evidence suggested a low carb diet was simply the best way to help him achieve metabolic health. Now, that was based on randomized clinical trials. Now, today's guest not only understands the importance of making decisions based on good evidence, but he also works for the Diet Doctor website, which attempts to do the same. Today's guest is Dr. Brett Sher. Dr. Scher is a board-certified cardiologist and lipidologist practicing in warm and sunny San Diego, but is licensed to practice in 7 states. He is a full-time medical director with the Diet Doctor. He writes blogs. He hosts a very popular Diet Doctor podcast as well. Dr. Scher's focus is focusing on preventing and reversing heart disease naturally rather than putting patients on medication and performing surgery. He's also obtained a lot of certifications, one of which I was very proud to see, which is functional medicine, particularly since I'm getting that training myself right now, nutrition, personal training, and behavior modification. He's also author of a book entitled The Best Health Ever and has a blog and website at low-carb-cardiologist.com. And Dr. Scher, I wanted to welcome you to Protecting Your Nest.
Yeah, thanks so much for having me, Tony. It's a pleasure to be here today with you.
Yeah, I'm excited. So other than this functional medicine training that I didn't know about, I was also intrigued that, your book came out the same year that I wrote the Fix Your Diet, Fix Your Diabetes. So we actually kind of got into the writing game around the same time, which was really cool. So I really appreciate you being here. You were instrumental in me getting involved with the Diet Doctor, and I want to thank you for that as I try to write a monthly column with you guys and just add value. And I think we all have to play our part as we do that work. So thank you for that. But I do want to get started with a question related to your past. In other words, where you grew up and a little bit about your family, your family right now.
Yeah, well, thanks. I grew up here in San Diego. I was fortunate enough that my parents moved out here, and I was born here. And we look around and say there aren't too many natives in San Diego because so many people moved to San Diego because it's such a great climate. And then went to Stanford for college, and then went to Ohio State for medical school. And as much as I liked Ohio State, 4 years of Ohio weather for a San Diego kid was enough for me. So I came running back to San Diego for my residency and fellowship, and did a combined general and preventive cardiology fellowship at Scripps Clinic here in La Jolla near San Diego. And I've been in San Diego ever since. And I've got a wife and 2 great boys. And that's sort of where I'm at now.
All right. I love it. Well, I'm jealous. I think we're still in the 50s in Chicago in May, and we're halfway through the month. So I'll get over that, hopefully. But I appreciate the stories that you just shared. And I want to do a little bit in terms of thinking about the Diet Doctor, which has really gotten, they've done a great job of just being a reliable source of evidence-based medicine, right? So now you're their medical director, and I'm curious, tell the story about how you became their medical director, and also how what they believe aligns with your beliefs.
Yeah, it's a great question. So I was already sort of practicing as a low-carb cardiologist when I came across Diet Doctor. I was lucky enough to sort of work with a health coach who introduced me to low-carb. And from there, as you've probably said and heard many times, once you see the science and the practical implications and the clinical success of low carb, you sort of can't unsee it. So I was all in at that point. And I had my own podcast, low-carb cardiologist podcast. And at that point, Diet Doctor approached me, and it was actually Dr. Andreas Einfeld, the founder of Diet Doctor, and said, "Hey, how about you come work on and host our podcast for us?" And I said, "Sure, that sounds great," because I already knew Diet Doctor was the leading low carb website in the world, and they're such a mission oriented company. And, they don't sell ads, they don't take outside money or push products. They just want to make sure that they are not unduly influenced, that they're focusing on the science and helping people as much as possible. So that was right along the lines of what I wanted to do. So first I started just hosting their podcast, and then they started giving me, a little bit of things to write and to edit here and there. And then, so that's my way of saying we dated for a while. We dated for about a year before we got married. And then, so after that year of working together, then they said, "Hey, we want to bring on a full-time medical director." And I was all in. I mean, I love the company as I got to know everybody in the company, and everybody just is so focused on helping as many people as possible and promoting the best lifestyles to do that. So we were totally aligned in our mission, and so it was kind of a no-brainer for me to join them when the offer came. And yeah, it's been almost 2 years now that I've been the medical director and still doing the podcast, and really just enjoying help create the content and make sure the content is as helpful and trustworthy as possible.
Yeah, I think that trustworthy part is critical. Even as a clinician, it's very tempting to get so indoctrinated into your beliefs that you fall into the same trap that people who think differently fall into, which is you're not really following the science. And I think about how you approach things. I think about people like Adele Height. I mean, she really like tries to look at things and really force us to think about it and think about it differently. And sometimes it's contrary to maybe the messaging that you want to give, but we have to be honest about that. Even when I wrote Fix Your Diet, Fix Your Diabetes, the goal was to write a vegetarian based book. And then I started looking at the science, and it just wasn't matching what I thought I knew. And you have to be honest in those moments and reflect and maybe turn the ship in a different, just like that, Professor Tim Noakes, he had to turn his ship in a different direction. So that's very interesting. And I kind of felt some of your comments before you said it. I felt that would be
Mm-hmm.
true for you. So my
Yeah.
organization with Advocate Aurora, well, go ahead. You want to
Yeah,
comment?
I'm sorry. Yeah, but I was gonna say, I think we sort of have to be honest that it's hard to do. It's exhausting to question your beliefs and to question everything. It can be very tiring and a lot of work to make sure you are truly investigating and supporting everything you say. It's so much easier to just go with the status quo, right? So it's hard, and I constantly struggle with it too, as does everybody. We're not perfect, but we can certainly strive to be better all the time. And Adele's one of those people who really helps sort of keeps me in line and keeps me questioning my beliefs. And same with Andreas. And it's so helpful to have them around.
I think we can play a role in encouraging our colleagues to think this way as well by just modeling that. And hopefully, as we model that approach where we're listening, I literally share the, a Facebook Live with a vegan. So we have interesting discussions, but I just think that it's important that we are able to dialogue, because I think we won't make progress if we don't. So thanks for that
Yeah.
too. And I also think about, my purpose is to help people live well, right? In fact, I work for Advocate Aurora Healthcare. Many of my listeners know that, in Illinois and Wisconsin. And our motto, help people live well. What does that really mean? So when you think about, if you had to define what living well means, how would you define it?
Yeah, it's a great question. I mean, living well really is all encompassing. It means mental, physical, and emotional health. And all of those combined mean living well. And if you have two, but not one, you notice, right? And your quality of life suffers. It really takes sort of all three to live well. And I mean, you can get down to specific markers, right? Some people may say living well or living healthy means having a normal blood pressure or having a normal blood sugar. Well, sure, those are part of it. And those are part of it in terms of like what type of complications and what type of vitality will you have in the future. But it's finding a lifestyle and a way of living that combines all three of those aspects to help you feel good, feel vibrant, accomplish the things you want to accomplish, whether that's creating a new business and changing the world, or whether that's spending time with your grandkids, or being able to get outside in nature and go for walks, or whatever your goals are. Living well means being able to achieve that comfortably and enjoyably and do it in a healthy way.
I remember listening to inspirational video, and they tried to define what being happy was, and it rarely is getting to a goal necessarily. It's really the journey, and if you can if you know you're working towards something that means something to you, you'll be happy. It's really that simple, and being happy is kind of what we all want anyway. So, that's a very logical way of thinking, and I learned a lot about it just allowed me to reflect. And I said, well, am I living my purpose? Well, doing this work with you today, that helps me live my purpose. Seeing the patients I saw earlier today, making sure I text my wife and said, I love you today. You know what I mean? Those little things matter. And that's the type of stuff that you have to do. So, prior to this podcast, we did a brief video highlighting the various markers of metabolic health. And we compared how a low carb diet plan responds to how your markers respond versus a low fat. And for those who are listening, we'll definitely make sure that video is on YouTube in the very near future. But do me a favor and speak to the evidence that supports a low carb diet as maybe being a better option for people who are trying to achieve metabolic health.
Yeah, that's a great point. And I love that you're using the term metabolic health, because I don't know about you, but when I was in medical school, I don't think people talked about metabolic health. They talked about
No,
diabetes and
not
they
at all.
talked about LDL cholesterol, and that was it. And there was like sort of nothing in between. But now the in between is where all the action is. That's where everything, it's so important, that in between, because that really says so much about our health and our risk for future diseases, and our potential for living well and living a vibrant, healthy life. And so when it comes to metabolic health, the evidence that low carb diets are beneficial, and probably more beneficial than low fat or other comparative diets, is very strong. I mean, this isn't just like one-off studies here or there. It is a compilation of data that shows that low carb diets are probably the most effective nutritional intervention for reducing body fat, and specifically abdominal fat and visceral fat. The sort of the most dangerous or riskiest type of fat is that abdominal fat, but also doing it in a way that improves your blood sugar and your insulin, right? So insulin, as I've mentioned before, is sort of like the canary in the coal mine, because by the time your blood sugar is abnormal, that means your body has been fighting metabolic dysfunction for years, if not a decade or more. So by normalizing insulin before you have any blood sugar issues, that's such an important measure of metabolic health. But also, when you talk about lipids, it's not all about the number of LDL cholesterol, the concentration of LDL cholesterol, because when we talk about the type of LDL, the smaller, denser LDL has a higher association of cardiovascular risk than other types of LDL. And low carb diets, no question, are better than other diets at reversing that small, dense LDL and making them into the larger, less dense LDL. They're also better at improving triglycerides and HDL, which is not just a marker of metabolic health, but also a marker of the type of lipids you have in your circulation, and therefore the future cardiovascular risk. So taking all of these combined really shows how low carb diets improve metabolic health from top to bottom, from soup to nuts, however you want to say it. But low carb diets can really impact all the various aspects of metabolic health, and probably do it better than most other diets. Now, the other part of this, though, is, to be honest, this is not the only approach to do all this. Very low fat diets can do it. Higher protein diets, whether they're low carb or not, can help metabolic health. But when you take all the evidence together and try and compare all the different diets, it certainly appears that low carb diets are best. So maybe low carb, higher protein diets are even better for some. Or low carb, low calorie diets may be better for some. The key is finding the version of nutrition that you can sustain long term, that doesn't leave you hungry, that leaves you feeling good, enjoying your meals, because let's face it, we're humans, we like to enjoy to eat, but also does that in a way that improves all these metabolic parameters. And low carb diets definitely fit that for a large number of people.
Well, you did it again. You expressed your opinion in a way that was allowing for people to have some wiggle room, right? So you're not saying it has to be low carb, doesn't have to be very low fat, doesn't have to be Mediterranean, doesn't have to be any of those things. We know that the standard American diet is not the right answer. So I think for everybody listening, you almost have to do your own little experiment. And if you are attempting to improve your diabetes, you can easily eat a certain food item and see what happens. You could easily compare it to the other food items. So I think it's important that we, follow diets that allow us to, evidence suggests they're better, but we also want to do our own little experiment. And what you'll find is that you don't have to do it just one way. I just think that for a lot of Americans, who have insulin resistance, it makes sense to reduce the thing that stimulates insulin, which are carbs. So I appreciate that. You also mentioned as you began that, one way to live well is to do A, B, and C. And it's rare that cardiologists would recommend intermittent fasting. So I know in the past you've talked about intermittent fasting. I want you to just comment a little bit about that and what you've seen. I know we got people like Dr. Jason Fong out there who are really experts in this area, but what's your thoughts about intermittent fasting?
Yeah, intermittent fasting is really interesting because, again, if you would have asked me about it when I was in medical school or residency, I would have said, "What? What's that? Why would you not want to eat? Of course you have to eat all the time." And it's something that we're not taught, but now we've seen this explosion of literature and science based on it, showing that the mildest version of intermittent fasting, a time restricted eating of 12 hours, 14 hours, 16 hours fasting, can help people lose weight, improve their lipids, improve their blood pressure. And it's a way of reducing calories without stimulating hunger as much, and still maintaining your resting metabolic rate and your lean muscle mass and allowing your insulin levels to drop. It's just one more tool to be able to do that. So I think that's such an important factor that everybody should experiment with. Now, one caveat is, though, it's not for everybody, right? Some people, when you spread out your meals, get hungry, and then when it's time, they're counting on their watch when it's time to eat, and they're just thinking about food. So when their window's open, they go at it and they eat and eat and eat, and they sort of eat more than they otherwise would have. And some of that does undo some of the benefits. So you have to be, clear in your mind of what you're trying to accomplish by time restricted eating, and making sure that the rest of your day doesn't make up for not eating that time. But when done right, it is so powerful. But then you can extend it to, alternate day fasting, 3-day fasting, 5-day fasting. And those all have some added benefits, although come with added challenges and added risks. So I think it also has to be, or should be, done with support. Especially if you're on medications or have any pre-existing medical conditions, you have to be very careful about fasting, but also making sure, the longer you fast, the more you're at risk of losing some lean muscle mass. You have to make sure you're using your muscles and continuing to try and counteract that effect. The longer you fast, probably the less often you should do it, because you don't want to get into the what I would say is the area of chronic caloric restriction when you are sort of lowering your resting metabolic rate, which makes it then harder to maintain weight loss. So you have to factor in some of these things. So, simple time restricted eating, I think people can do every day, but again, have to do it with a goal in mind and making sure your eating window is you're still eating appropriately. And then if you want to do extended fasts, do it with some clinical guidance so you get the right mix of duration of fast and frequency of fasting, and making sure you're doing it safely. Because there's no question, if you do it right and if you do it safely, there are great benefits to be had from weight loss and metabolic health standpoint.
Absolutely. One thing that I want to emphasize is that there will be some people who just can't tolerate fasting, and it's totally okay. But for most people, and you're going to be hungry your first few days around lunchtime, but every day that passes, for most people, that what it's going to take to make you get past that is going to get easier and easier, and your body just kind of adapts. And most people who do intermittent fasting will find that their hunger will actually go down. And most people who do intermittent fasting will find their metabolic rate will go up, not in a major way, but it certainly goes in the right direction. So I think that depending on how your body responds, you will absolutely benefit. I think for me personally, it's been a game changer. And some days I have to remind myself to eat. So I think for everybody who's doing this, you have to listen to your body and don't feel like you have to be obligated to do any of these approaches. Just kind of do a little bit of experiment to see what works for you. The other thing that I absolutely wanted to talk to you about is this idea of red meat. And I know you've done some videos recently talking about that topic, and there's a lot of debate in that area for sure. So, and I mentioned earlier that I do a Facebook Live with Danny Davis, Congressman Davis, Monday nights, and we do this from Chicago. And we certainly have a well-known vegan who's part of the panel. And so imagine that you're me and you met my colleague, and he was very much a vegan and felt that meat was harmful. So how would you talk to your respected colleague and have a conversation about, meat versus the approach that's more vegan, and why meat may not be as harmful as we once thought?
Yeah, that's such a great question and so important, because it seems like nutrition has become so polarizing. Like you are a vegan or you are a low carber, right? And like it's your identity, it's who you are. And it's not. It's what you eat. It's not who you are. But I think because of that, it has become so polarizing. I can't really think of a better word. But it doesn't mean there isn't room for nuance and discussion. And so I love that you regularly have a discussion with someone who's vegan. It shows you can have, gentlemanly, evidence-based, friendly discussions, even if you disagree. So I think one of the keys is to focus on quality of evidence. And this is something that's so important that, again, is misunderstood. And what is the quality of nutritional epidemiology studies? Because that is, when you look at the evidence against red meat, the overwhelming majority comes from nutritional epidemiology studies. And there are some people who say, look, if you have 100 studies that all say the same thing, it must be true. Whereas the flip side is, well, if you have 100 studies all with the exact same faults, all with the exact same confounding variables that are, of course, going to find the same things, then the more you have doesn't help. So I think part of it is this concept of how you see nutritional epidemiology, because when you look at these studies and you look at the baseline characteristics at the start of the study of those who eat more red meat and those who eat less, across the board, those who eat more red meat at the start of the study are more likely to have diabetes, more likely to smoke, more likely to drink alcohol, less likely to eat fruits and vegetables, more likely to eat more calories, less likely to exercise. So there are all these unhealthy characteristics and lifestyle choices that those people are already making at the start of the study. So then when you follow them for 10, 15, 20 years, and they have a worse health outcome, and your conclusion is, aha, see, it's the meat. Well, wait a second. How about, aha, it's because you were eating more calories. Aha, it's because you were drinking more alcohol. Or aha, because you weren't exercising or not sleeping well, or because you were more stressed out, or because you weren't taking your multivitamin, or you weren't seeing your doctor. There could be 1,000 things. I mean, to think that we can control for everything in that study and account for everything in that study, that we can boil it down to the meat. I mean, I kind of don't understand how people can still believe that, but people do. And so I think I would have to start with this discussion about what you think the strength and the role of nutritional epidemiology is. Then the next thing, though, is to say, okay, let's assume we say we're going to believe these trials. And that's okay, because if you do as a vegan, that's okay. So what does a hazard ratio of 1.2 mean? Because that's what a number of these studies, and I shouldn't call them trials because they're not trials, they're observational studies, but that's what a number of these studies show, is that the higher risk for those people eating more red meat is a hazard ratio about 1.2. Well, to put it into perspective, the hazard ratio between smoking and getting cancer is somewhere around 15 to 30, not 1.30, but 30. So here we're talking about 1.2. So we're talking about a minuscule difference, right? So now let's take that difference and say, you're talking to this person in front of you, this one patient. What is their risk? If the general population increased risk might be 1.2, what does that mean for the individual in front of you? And there's really, to me, that's not a meaningful difference. So the next question, though, is could they get some benefit by eating meat, and what are they giving up by not eating meat? Because I think part of the assumption is, well, you don't get any benefits. It's all bad. So giving it up has no downside. So why wouldn't you give it up and just be a vegan? But it is meat is a fantastic source of protein. It's enjoyable. And if you increase your protein by eating meat, you can naturally eat fewer calories. Meat as part of a low-carb diet has been shown to improve metabolic health and even improve cardiovascular risk. So the meat can absolutely be part of a healthy diet. It's full of vitamins and minerals and nutrients that you might not be able to get from plant food. So it does have benefits and positives. So I would start the discussion with, around those topics to just to try and help them see things from a different perspective. And hopefully they would be able to, maybe open my eyes to some of my biases and some of my assumptions. But yeah, I think to me, I think there are too many assumptions and people are too sort of rooted in their beliefs to open their eyes to some of these discussions.
And I just want to be clear. So the higher that number for the hazard ratio, the more likely, it's more probable, just so people understand.
Yeah, right.
Yeah, so I just want to say that out loud. So these are the kind of things they teach you when you're in school, if you're paying attention, and it's really important because we don't want our clinicians to hear headlines or just go to the research study and read the abstracts, which is the summary. We really want to look at the quality of the study, not just rather it's a epidemiological observational study where you get surveys compared to a randomized controlled trial where you actually control things and know exactly what's happening. You want to see if there's bias. You want to know, who was in the study. You want to know all of these, who paid for the study. You just want to know all of these things because without that information, you may get information that won't really serve you. So I think it's important that we think about it in those terms. And so when we're having a conversation, there are certain things that we have to ask ourselves before we even talk about the study. Let's get those details out of the way. And that way, for example, if I want to do research, which I'll probably be doing in the very near future. And, but I have to say up front, I tend to promote low carb. You need to know that before you read the study that I had my name on. It's just important to know that. So there's some built-in bias that's going to be there. So, and that's okay. As long as we know that in advance, we're okay. So that's really important. Now, you mentioned the LDL cholesterol earlier, and that's the other elephant in the room that leads to concern. Some docs are like, I'm not worried about that. And sometimes they go too far with that. And then other doctors say that's the most important thing to look at. So as an expert on matters related to cholesterol, I want to hear how you approach the LDL cholesterol question.
Yeah, it's a great point, and there is no one answer. But I think the clearest way I can say it is that not all LDL is the same, and not everybody's cardiovascular risk is the same. And how you interpret LDL has a lot to do with the underlying cardiovascular risk and the specifics of the LDL and the metabolic health. And there is evidence going all the way back to the Framingham Heart Study that, an LDL of 100 with an HDL of 25 or 35 is much more likely to lead to cardiovascular disease than an LDL of 220 and an HDL of 65. Right? And you would think if LDL was everything, that wouldn't be the case. But no, because that LDL of 100 with the HDL of 25 is much more likely to be in the environment of poor metabolic health and small dense LDL and high triglycerides. And so even though you would say the higher LDL is the risk, or many people would say higher LDL is the higher risk, that study showed it not to be the case. And the same with what's called the 4S trial, a statin intervention trial. When they broke it apart and looked at the people who had the high LDL plus high triglycerides and low HDL, they definitely benefited from a statin on average. But when you looked at what they called the isolated LDL, which means the low triglycerides and high HDL, they actually did not benefit by getting a statin. So it's a different situation. Now, does that mean we can just ignore it if HDL and triglycerides are okay? Well, no, there we can't necessarily ignore it either. It's still a risk factor, but its impact certainly can diminish. It can go up and down with the rest of your metabolic environment, with the rest of your cardiovascular risk, with your family history, with your blood pressure, with your inflammatory markers, and possibly even with a calcium score. All of these things can impact your risk, and LDL is one piece of that. Now, even better than LDL is what your ApoB. Apolipoprotein B is now being recognized as an even better marker than LDL, and the science is pretty clear on that. But the other concept, though, is, okay, with a low-carb diet, or with a high-fat diet, or high saturated fat, or animal products, however you want to phrase it, does that automatically mean your LDL is going up and you're at risk? And the answer there is absolutely not. But that's an assumption that so many people have, doctors included, that anybody who's eating saturated fat or low-carb or animal products is going to have a high LDL, and therefore that's dangerous. But when you look at the data in the trials, it actually says the opposite, that the majority of people do not have a rise in their LDL or their ApoB. And if you calculate their cardiovascular risk, on average, it goes down. On average, right? There are going to be people who have a high elevation of their LDL, and they're going to have people who have a lowering of their LDL. There's natural variations in these trials, so we can talk about the average. So for those outliers that do have a high LDL, then the question is what to do about it. And that's where you have to factor in the overall risk and put it into the bigger picture. So I don't wrap it up and throw it in the trash bin. I consider it as one piece of the puzzle, with all the other factors having an equal, if not greater, role than the LDL.
Yeah. And I actually want you to define that term hyper responders, because you triggered me when you started talking about, how people respond differently. But what comes to mind right now is, I know we have these risk factor calculators. So I'm thinking in my brain, it seems like we should be flexible, in that we should have kind of a risk factor calculator that's updated. And we need to be flexible in that it may change, because we're constantly coming up with new information. And I think what happens, we get so rigid, and we get these calculators, and then it stays the same for years and years, when we really should, be flexible, metabolically flexible in a sort of way. So I think that would be, but speak a little bit about the hyper responder, so people who are not familiar with that term, they'll know what it means.
Sure, and I'd be happy to. And I also want to address the concept of the risk calculator too, because you have to realize, where did the data come from to create this risk calculator? And it came from these large observational studies. Well, how are most people living their life and eating, and what is their metabolic health in these large observational studies? And the answer is poor. On average, it's all poor. So does that then apply to people who are eating low carb and are metabolically healthy and are improving their health in so many other ways? Probably not. All right. So do we have reason to think that would be different? Absolutely. Biologically, there's plenty of reason in science to say that would be different. So we have to realize that doesn't apply to everybody the same way. It applies to a general population in the studies. So you asked about hyper responders. Now, as I mentioned, the majority of people and the majority of the studies about low carb diets shows that LDL does not go up. But we definitely have this subset, and it's hard to know exactly how big the subset is, maybe 10%, maybe 25%, where LDL does go up substantially for those following a low carb diet. Now, it also happens to be with wonderful HDL, triglycerides, low inflammation, low blood sugar, low insulin. All those things sort of go together. And, I think Dave Feldman is probably one of the most well-known people for talking about the hyper responders. And one thing he says is he's never come across anybody who says, yeah, I'm a hyper responder and I feel terrible on this diet and my health is deteriorating and I want to give it up. It's quite the opposite. And I'm the same way because I see all these patients who are hyper responders and across the board, they're like, yeah, but I feel better than I've ever felt. I'm losing weight. I've improved my health in so many other ways. And it's just this pesky lab value. Otherwise, I feel phenomenal. So what do I do? So that's sort of this bucket of people we call hyper responders. And it is sort of uncharted territory. We don't have much research on them. And so there are I guess there's more than two ways to approach it, but you could say there are three ways to approach it. One is to say, look, the evidence we have shows LDL is bad, therefore it's the same in everybody and needs to be treated the same in everybody. The other way to approach it is, look, there's no evidence about high LDL for people following a low-carb diet who are otherwise metabolically healthy. Therefore, we should assume it's perfectly fine until we have data otherwise. And then there's the middle ground, and I'm frequently a middle ground kind of guy. And it says, look, we don't have evidence to say it's harmless or beneficial. That's overwhelmingly convincing evidence. And we don't have evidence to say it is harmful and extremely dangerous in this subset. That's overwhelmingly convincing evidence. So we have to realize we're in uncharted territory, and we can keep walking forward, but we have to tread carefully and with our eyes open and with more close monitoring, and trying to detect signs of cardiovascular disease or increased risk in other ways, rather than just ignoring it. And so that's where it seems like a cop-out to say it's an individualized approach, but it really is, because it has to do with what are your concerns, what are your fears, what are your goals, and what is the rest of your health history. All that plays into how do you address this one topic. And I think, we try to boil it down too much to, well, is it good or is it bad? Just tell me what to do. Do I need to worry about it or do I not need to worry about it? And it's not always that simple.
As the healthcare system continues to hopefully transform, it's easier for clinicians to do a better job if they're given more time to do the job. And I think it's hard to be a thinker. So part of the rush to put people on medicines and to take an approach that doesn't require thought is it's easier, it's faster, and it's very tempting. But that's what we have to push back. So I hear you. It's tough, and I think we all struggle with that. And one of the things I struggle with it's kind of funny actually. I have patients sometimes who see me and maybe I even ordered the coronary artery calcium score test, and then they get a 0 score, but then maybe they saw the cardiologist or the other doctors who they've seen in the past, and they want to still put them on a statin. So if you were me and you had a patient come to you saying, "Hey, I have a 0 score. I'm 65 years old. The other doctors think I should take a statin." I know that you need more data to answer this question, but I just want to get a sense of how do you handle conversations around taking medicine just because the guidelines say you should regardless, maybe they're diabetic or something, right? So how do you handle a situation like that?
Yeah, it can be tricky, especially when they're hearing different things from different doctors. And that's, I feel so bad for so many of these patients who are just trying to figure out what's the right thing to do. And everywhere they turn, they're getting different advice. And it's like, it's enough to like just make your head explode and make you want to give up almost sometimes as a patient. And I feel so bad when I hear those stories, but I get it. And it happens so often. But a 0 calcium score is a pretty powerful predictor. I mean, there was a great study out of Walter Reed Medical Center showing that when you take the group of people that have a 0 calcium score and follow them for 10 years, those who got a statin and those who didn't get a statin had absolutely no difference in terms of who lived or died, who had a heart attack or didn't over that 10-year period. Now, of course, like any study, there are caveats, were the people whose LDL was 400 in this study? No, because it's considered standard of care if your LDL is above 190 that you get a statin, period. No further evaluation required. So we have to understand who was in that trial. So short of the 190 mark, that trial is pretty powerful that a calcium score of 0 is a very good 10-year predictor that you don't benefit from a statin. But there can be other, markers or other things to consider within that. Now, what do we do with those people who would not be included in that trial, whose LDL is above 190, who the reflex is they must be on a statin? One of my problems here is that the assumption is everybody with an LDL over 190 has familial hypercholesterolemia. That's sort of like the scientific and the guideline assumption, and that is absolutely not the case. And that's what we're seeing so much with low carb diets. I mean, I can't tell you how many people I see in consultation where they said, my cardiologist tells me I have familial hypercholesterolemia. And I say, well, okay, were you ever told you had high cholesterol before you started a low carb diet? No, my LDL was 130, 3 years ago. Do you have any family members with high cholesterol or premature coronary disease? No. Okay, do you have any physical exam findings of high cholesterol? No. All right, you don't have familial hypercholesterolemia, right? There's criteria to diagnose it. It's not just LDL. So that's, again, part of the assumption we need to get away from. And that's part of the reason why so many people with a calcium score of 0 but very high LDL, they're still recommending statins. So again, there's not one approach, but the first approach is stepping back and realizing that this is a different scenario than what most of the guidelines are including, and therefore seeing it through a different lens than the traditional standard, everybody's the same guideline.
And what I like about the word guidelines is that it's a guideline. It's not the rule. Unfortunately, it's being interpreted as the rule that you have to follow. And I think if you document your rationale for decisions that you're making, that should be enough to allow you to make decisions that have been individualized for that patient. So again, any clinician listening, their guidelines. Now, of course, I want you to document because we still live in the real world. But it is important that we look at the individual because we don't want to cause harm, and everything we do to patients can potentially cause harm. So I think we both are familiar with Dr. Tro, wonderful doctor. I think he's been on your podcast. And, what I love about him when he was on my podcast is that he talks about focusing on helping patients who struggle, deal with this hunger issue. So I'm learning over and over again that if I don't address hunger with my patients, they're going to struggle. So what's your thoughts on the importance of dealing with hunger as we help patients achieve metabolic health?
Probably the single most important factor for sustainable healthy weight loss is hunger. And that's where our recommendation for a low-fat diet, eat less, move more, just fails horribly because it increases hunger. And any lifestyle intervention that doesn't address hunger is destined to fail, period. I mean, we are human beings. We don't want to be hungry. We're emotional. The hungrier we are and the more emotional we are, the more we're going to overeat. And if we don't like the way we're feeling, we're not going to stick with it. So any lifestyle intervention that doesn't address hunger is destined to fail. And that is what is one of the primary reasons how high protein diets work so well, how low carb diets work so well, and certainly how a combination of a low carb, high protein diet works so well is because it addresses hunger. High satiety for the fewest amount of calories is the secret to success. And then how you achieve that in ways that also improve your metabolic health and lower your insulin and improve your body composition and all that. I mean, that is the process that we need to go by. But I think since we are humans, starting with hunger is number one, which is a big reason why I also don't like so many animal studies where it's like a controlled feeding study where, they eat when they're given food. That's not us, right? We've got a convenience store down the block, and we've got the doctor's lounge over here, and we've got the vending machine over here. Like, we are surrounded by bad choices. And if we're hungry and emotional, we're going to make those bad choices. So absolutely need to address that. And I think Dr. Tro is a big proponent of that. And I'm glad he is, because that's a message we need to get out there. If you want to eat low fat, high carb diet, look, there is science supporting metabolic health benefits to low fat, high carb diets. But if you're an individual who stimulates your hunger on a low fat, high carb diet, then you are destined to be unhealthy on that diet. If you aren't, if you can be like a traditional Okinawan and eat 80% carbohydrates from, real food carbohydrates, high fiber carbohydrates, and not stimulate your hunger, all right, then that might work for you. But for the majority of Americans in the society we live in now, that doesn't seem to work for most people because of the hunger and the temptation and the cravings.
Yep. And when I was a vegetarian and at times I was a vegan, um, I felt fine. I think I was doing fine, but I definitely ate a lot. I kind of felt like I was grazing like a cow just all
Hmm.
day just to kind of keep that hunger. And I kind of got I think Dr. Ornish is the doc who doesn't like the oils, if I recall. I don't remember if it was Ornish or Esselstein, but one of them doesn't
Oh,
like the oils. And I tried that for a while and it was tough, to do it that way. So I think again, you have to listen to your body and what's I want you to do the best diet that's evidence based that serves are the people who are listening well. But you also have to do something that's sustainable. And what I find is that as I eat a low carb, high fat diet, it's so sustainable and it's so easy. And I just love it. So again, let people kind of experiment on their own and figure it out. One thing I'm very excited about as a board certified obesity medicine doc is that the Obesity Medicine Association thankfully does have an algorithm that includes a low carb diet as one of their dietary options. And the American Diabetes Association now has a low carb and a very low fat diet as well. So it's really kind of cool that we're moving in that direction. What's your thoughts on what's likely to occur over the next several years as more awareness about metabolic health and how low carb can help us achieve that? Do you think we're going to get these other organizations? I think about the endocrine docs. I think about the cardiologists like yourself. They're kind of moving a little slower in this direction. What's your thoughts on what's going to happen in the future?
yeah. I mean, I think the endocrine docs, the endocrine society has to get on board because of the beneficial evidence for type 2 diabetes and for even controlling type 1 diabetes with fewer hypoglycemic episodes, better quality of life, lower insulin requirements. So type 2 and type 1 diabetes benefits, I think the endocrine societies are going to have to start paying more attention to that literature and getting on board. I, I've got to be honest, I'm pretty skeptical about the cardiologists ever getting on board because they are just so entrenched in the low fat mantra, and the LDL is everything and saturated fat is risk mantra. I don't have much hope for them changing anytime soon, but I don't know that they have to. Um, I think it's so much going to be driven by primary care doctors like yourself who really have that strong relationship with their
Mm-hmm.
patients and are looking at the whole patient rather than looking at just their lipid numbers or whatever the case may be. And for a primary care doctor, you've got all the support you need now to realize that a low carb diet is evidence based, is safe, is effective, and is supported by major organizations as being safe and effective. So I think you've got all the evidence you need to promote it, but also to not say everybody should eat low carb, high fat. See you later. No monitoring needed. No, of course you still need to monitor them just like you would anybody else, and that's perfectly fine, and that's the right thing to do.
And it sounds like from your comments as a primary care doc to practice defensive medicine, sounds like I need to document well and just understand the science and just make sure I put on paper my rationale. Rather it's a side effect of a statin, rather it's some other reason the data doesn't support it for this particular patient. But it sounds like that's what I should do is document well until the guidelines change and maybe get a little bit more education related to that area. What's your thoughts?
Yeah, I mean, I hate the term defensive medicine because it implies that you're practicing in a way just to protect yourself. But it's such a ubiquitous term that I know that's not what you meant. But I think some people may think of it that way. But I think the key is
No
with
doubt.
anything you do, everything is a risk benefit analysis. Anything is a shared decision analysis with your patient. So you should never tell your patient you need to go on a low carb diet. You say, look, you have type 2 diabetes, you are obese, and you have high inflammatory markers, your blood pressure is high. There are a number of studies showing that all of these can improve with a low carb, with a keto diet, with a high protein low carb diet. And so I want to suggest that you try one of these. Here are some resources to get you started. These are the markers we're going to follow to see if you're having metabolic success. And of course, you document how you're feeling and keep track of that. And then let's come back in 6 weeks and see how you're doing for an update. And I think that's all you really need. It, Nobody would be able to say, you told me to try this, crazy diet that didn't work. And now look at me, I'm sick. And it's like, well, no, we had this discussion. We decided together, this is how we're going to follow it. And this is the science behind it. And that's medicine. That's what you should do for anything, whether you're giving a beta blocker, whether you're giving a statin, or whether you're telling someone to be vegan. You should have that
That's right.
exact same discussion.
That makes a lot of sense. So I'll put that in my back pocket, and that's the approach I've been trying to take, and it's working. And thankfully, I'm in a health system that allows us to be independent clinicians, and we just are guided by guidelines, but we also are guided by the knowledge that we've acquired. So, and one of the things that I really appreciated, I mentioned earlier, is this certification in functional medicine. So, what role has your knowledge about functional medicine played, since so many of our colleagues have no training in that space at all? What has that done for you in your clinical practice?
Yeah, the funny thing when someone says, "How do you define functional medicine?" and it's like, well, it's more about getting to the root cause of a condition rather than just treating the symptoms. And the response should be like, well, shouldn't that just be medicine? Like, why do you need the term functional for that? Like,
Right.
that's the way we should be practicing medicine anyway. We should be trying to get to the root cause, and it shouldn't be this like revolutionary new concept that needs a whole field to say we should get to the root cause of things
Right.
rather than just putting on band-aids. But that's sort of what functional medicine has done, and has really brought up this new quote unquote new approach of saying, well, let's find out what's really causing these conditions and get rid of them, so you don't have to take medications. So you don't have to worry about just sort of like trying to manage
Right.
complications, but you get rid of it from the beginning. So for me, that's sort of like the underlying message of functional medicine that I think is so important, that I think should just be medicine.
And that's how I think now. I honestly didn't know I wasn't getting to the root cause. I
Hmm.
mean, isn't diabetes a high blood sugar? So therefore I need to just control the blood sugar. I
Yeah.
didn't realize that that was kind of a symptom. It was a symptom. So I think that that was like the biggest aha moment I had when I wrote my first book. It's like, oh, I'm treating the symptoms. I'm actually giving Tylenol to a person who has pneumonia. I'm not really giving them antibiotics, and then the question is, why did they get the infection in the first place? So you got to
Yep.
keep asking why until you get to the root cause. And that's what I love about functional medicine as well. It just changes. Again, it's how we should practice, but we weren't trained to think that way. I also want you to comment a little bit about your book that we wrote the same year. Both our books, Your Best Health Ever. Haven't had a chance to check it out yet, so before I grab it, I want to know what I'm buying. So tell my listeners what they're going to get when they buy your book.
Yeah, it's meant to be an overview of how to live a healthy lifestyle. And what does that mean? From goal setting and accountability to nutrition and exercise and stress management. And sort of what are some of the common perceptions and misperceptions that we have to get past to really find out what works for us as a healthy lifestyle. And things like everybody should be eating a low salt diet. Is that evidence based? Absolutely not. Everybody should be eating a low fat diet. Is that evidence based? Absolutely not. So it's about getting more granular, but also making it very simple about how you can learn what works for you and the general concepts that you need to put into place, but also not to get too caught up on any one thing, to focus so much on your nutrition when you're sleeping 4 hours a night and you're stressed out beyond belief and you're not getting any
Right.
exercise, right? Like, yeah, nutrition is still important, but is that going to undo all the damage you're doing with your other parts of your lifestyle? So it's really trying to get the main pillars of health all in line and finding a convenient and evidence-based way to do that so that you can succeed long term and not have the yo-yos and the ups and downs that so many people have in trying to find a healthy lifestyle.
So in other words, your book should have been entitled "Protecting Your Nest," because that's exactly, what I do. Yes, that's exactly what I think. That's exactly what I do. So when I write my next book, which with that title, I'll just have to just read yours and just write what you wrote. So that's excellent. So I appreciate that. That's pretty cool because most people, particularly in your field, probably would not broaden it. But I'm sure your training in functional medicine and others has really given you a perspective that allows you to see the world through a different lens. So So Diet Doctor, what a valuable resource they've been. And again, thankful that I'm kind of part of the team now as one of the low carb experts. I want to ask you a little bit about what's on the horizon, anything new happening with the website, what's kind of happening with the Diet Doctor right now.
Yeah, dietdoctor.com right now. We've built the website as the low carb and keto website. We're the number one low carb and keto website in the world. And now we're starting to branch out to say, look, people have tremendous success with low carb and keto, but does everybody? I mean, some people have great success and then they stall. Some people may not want to be keto or very low carb. So what other options can we provide for people? So now we're really starting to focus on the higher protein approach as an alternative or as a way to augment the low carb approach. Because really our goal is to help people improve their lives, improve metabolic health, to have healthy weight loss. And look, we have to be honest, there's more than one way to do that. And low carb and keto is a phenomenal way to do it. So are higher protein diets. So right now we're really putting out a lot of new information about higher protein diets, so people can understand when it might be right for them and what does it even mean? What is high protein? Does it mean 50% protein where you're chugging whey smoothies all day and eating nothing but egg whites, or is it you can still have your ribeye, you can still have your chicken thighs with the skin on, but maybe you don't need to drown everything in butter and bacon, and instead you're adding higher protein foods like some shrimp or maybe chicken breast with some cheese or with the skin on, combining the higher protein and the fat foods, so you can find what works best for you. So that's something that's really exciting that we're working on now at Diet Doctor, to be more personalized. And as part of that, we've come up with a personalized meal planner where you answer questions about yourself, your age, your gender, your height, how physically active you are, what foods you like, what you don't like, what your health conditions are, what your goals are, things like that. And then we can pull from our over 1,000 recipes to come up with meal plans that fit your criteria and that our algorithm says is going to help you with healthy weight loss. And then as you progress, you can change things and iterate upon it so that we get a more personalized approach. That's another sort of exciting thing we're working on at Diet Doctor. And we're always trying to add more to help people with healthy weight loss, to help them improve their metabolic health, to help them live better, healthier lives. And we want to be able to, help people however however works best for them.
I was very happy to hear about the protein. And I did notice some articles recently that talked about protein. I just looked up the dietary reference intake report for macronutrients, and they say a sedentary adult should consume 0.8 grams of protein per kilogram of body weight, which is equivalent to about 56 grams of protein per day, and the average woman 46 grams. But the caveat is, many people are not sedentary. And what I've learned in my nutrition and functional medicine training is you can take that number up way past 0.8, 2.2, and higher. So if you're a very active person, you can probably consume more protein. And I also learned in my training that of the macronutrients, protein is probably the most important. It's the building block for so many things. So I'm really happy you guys are moving in that direction, because that's another myth, as we talked about earlier, about meat. We have to remove these fears about protein and, are they going to harm your kidneys and all these things that you hear about, and look at the science. And what you find is that the human body can tolerate a whole lot, and we need to be comfortable with that. So looking forward to that on the Diet Doctor. And I just wanted to make sure the audience was aware of that. So as we wrap up, I want you to kind of look towards the future for yourself personally. And I want you to think about that nest and rope, that book that I'm going to write that's going to copy yours, right? And I want you to think about your plans. I shouldn't advertise that. That's probably not bad, but think about your plans for the next year, and tell me, rather is nutrition, exercise, less stress, more sleep, how we think avoiding trauma. And I am going to write an article about trauma for the month of May, by the way. And also the rope talks about relationships, avoiding organisms and pollutants that don't serve us, and of course, protecting our emotions and our life experiences. So when you think about your year, what's going to be Dr. Scher's focus for the next year?
Yeah, that's a great question. And a big part of my focus is helping Diet Doctor grow and expand so we can help so many other people. But at the same time, it's also taking care of me and my life and my relationships with my wife and my children. And you know, eh, part of that is, as we talk about the nice weather and everything later this afternoon, I'll be in my shorts and t-shirt coaching my kids' baseball game. So that's part of what makes me sort of
Yes.
emotionally full and connect with my kids and connect with my family and give me sort of a bigger, broader purpose of helping raise my kids. And I just have to realize it's not about winning, right? I get so into the kids just want to win so much, but what I want is for them to learn and to grow and help mold them and how they respond to adversity and things like that. So that's a big part of my life in my next year. I mean, my kids are a very impressionable age, and I want to try and lead by example and teach them as best I can. And by leading by example, that means taking care of myself, taking time to exercise, taking time to take care of myself emotionally, taking time to make sure I'm prioritizing sleep and nutrition. And I have to be honest, my therapy and the thing I enjoy more than anything is just being outside in nature, riding my mountain bike, going hiking. So doing that as much as possible. All of these things are the factors that come into my healthy living and what I hope to prioritize in the upcoming year.
Awesome. Now we know we can reach you on Diet Doctor. Where else can my listeners find you if they need to?
Yeah, I mean, most of my content now that I'm producing is all on dietdoctor.com and the Diet Doctor podcast and the Diet Doctor YouTube channel. I do a couple of videos a week there. If anybody's interested in working with me as a patient, then Low Carb Cardiologist is the best place to go to learn more about that. But for my content, it really is dietdoctor.com and then Diet Doctor on YouTube as well. Oh, and Twitter at BSherMD
All
on
right.
Twitter.
On Twitter. Absolutely. So, I appreciate you taking time, and I think we're both busy leaving one meeting, going to the next, and that'll be our day. But I really appreciate you being here. Look forward to this interview. I'm excited. I remember when I was on the Diet Doctor podcast, it was a very, very exciting moment for me, and I'm just happy that we've kind of flipped it to the other side. So thank you so much for being here today, Doctor.
Yeah, it's my pleasure. And we're so thankful to have you helping us out at Diet Doctor, giving us your experience and helping us reach so many more people too. So thank you for all you're doing as well.
All right. Well, thank you for that. And as we wrap up, guys, using evidence not only is probably the best way to practice the art of healing, but is something our patients actually assume we do as we guide their clinical decision making. So, by paying close attention to detail and science, Dr. Brett Sher has used a very logical approach as he learns new evidence and makes clinical decisions. So, there's always going to be limitations with research, and there may be some lack of motivation because there's some profit tied to research that guides what they focus on. But I really wouldn't worry about that because we have a lot of good information already, and what we've learned is that so much of what it will improve health is actually related to lifestyle choices and dietary interventions. So thankfully, we have resources out there, guys. We have the Metabolic Multiplier website. We have the Society of Metabolic Health Practitioners. And of course, we have Diet Doctor, who really offers great resources for our consumers, but even more importantly, will help clinicians like myself because they have free medical education to help us learn how to achieve metabolic health in our patients and in ourselves. So I'm just happy that all of that exists, and I will continue to do my part to support Diet Doctor, and I appreciate them allowing me to be part of their team. So guys, as we wrap up, I ask that you do the same in supporting these great organizations. But more importantly, I want you to focus on you as your number one priority. So again, as we wrap up, I will always say to you, be safe, be well, and continue to protect your nest.